I'm Kaylee Duffy, and I did my project on mood disorders. An overview of this topic includes how everyone can feel sad or extra happy sometimes. Mood disorders are different because the moods last a long time and can cause serious problems in daily life, and how these problems can affect school, work, relationships, and basically everyday life. The learning objectives for this chapter in the textbook are being able to describe the diagnostic criteria for mood disorders, understanding age, gender, and ethnic differences in prevalence rates of mood disorders, being able to identify common risk factors for mood disorders, and finally being able to know effective treatments of mood disorders. Key features of this chapter are long-lasting depressed, super happy, euphoric, or very irritable moods. Symptoms caused distress. These symptoms interfere with daily activities. How common mood disorders can differ on age, gender, and race. There are many risk factors such as biological factors like genetics and heredity, as well as environmental factors which include having stressful life events and other external pressures. There are treatments for mood disorders like therapy, medications, and new treatments are being studied and show great promise. Short mood changes versus mood disorders. Everyone sometimes feels sad, irritable, or very happy. Mood disorders like major depressive disorder or bipolar disorder are very different because they involve long-lasting symptoms. They cause major distress and they interfere with daily life, like school, work, and relationships. Perinatal depression. Perinatal depression occurs after childbirth and affects 5% of mothers. This can often be made worse by social stigma, which is when people judge or misunderstand it. The DSM-5 criteria for a major depressive episode. A person must have 5 or more of these symptoms, including 1 or 2 for most of the day, nearly every day. 1. Depressed mood. 2. Loss of interest or pleasure. 3. Significant weight change or appetite change. 4. Insomnia and/or hypersomnia, which is when people sleep too much. 5. Psychomotor agitation or relentless or slowed movements. 6. Fatigue or slow energy. 7. Feelings of worthlessness or excessive guilt. 8. Difficulty concentrating or indecisiveness. 9. Thoughts of death, suicidal, or a suicide attempt. These symptoms cannot be caused by drugs, medications, or medical conditions like hypothyroidism. Manic and hypomanic episodes. A manic or hypomanic episode involves a period of abnormally high excited or irritable mood, increased energy, or goal-directed activity that is persistent. How long do they last? Manic episode. A mood change lasts 1 week or longer, or any length of time if hospitalization is needed. Hypomanic episode. A mood change lasts 4 days or longer. The symptoms of manic and hypomanic episodes include 1. Inflated self-esteem or feeling extremely confident or powerful. 2. Increased goal-directed activity or psychomotor agitation. 3. Reduced need for sleep. An example of that is feeling rested after only a few hours. 4. Racing thoughts of flight or of ideas. 5. Distractibility. 6. Talking more than usual or feeling pressure to keep talking. 7. Risky behaviors like spending sprees, risky sexual behaviors, and reckless driving. Unipolar mood disorders. They involve only depressive symptoms, meaning they do not include manic or hypomanic episodes. 2 main types. 1. Major depressive disorder, defined by 1 or more major depressive episodes and no history of mania or hypomania. 2. Persistent depressive disorder, has a long-lasting depressed mood and must feel depressed most of the day, more days than not, for at least 2 years. Persistent depressive disorder symptoms. Patients need at least 2. 1. Poor appetite or overeating. 2. Insomnia or hypersomnia. 3. Low energy or fatigue. 4. Low self-esteem. 5. Poor concentration or trouble making decisions. 6. Feelings of hopelessness. Symptoms must cause significant distress or impair daily functioning, not be caused by drugs, substances, or a medical condition. To qualify for persistent depressive disorder, the person cannot go more than 2 months without symptoms. Persistent depressive disorder and major depressive disorder can overlap if someone has a major depressive disorder episode during a persistent depressive disorder period. They are diagnosed with both persistent depressive disorder and major depressive disorder if that occurs. Bipolar mood disorders. Bipolar mood disorders involve both mood highs and lows, such as manic, hypomanic, and depressive disorders. The DSM-5 describes 3 major types. 1. Bipolar 1 disorder, also known as BD1. One's called manic depression, defined by at least 1 manic episode. A depressive episode may occur but is not required for diagnosis. Manic episodes often cause major impairment or require hospitalization. 2. Bipolar II disorder, also known as bipolar disorder 2. Involves at least one hypomanic episode and at least one major depressive episode. No manic episodes. If a person has a manic episode, the diagnosis becomes bipolar 2. 3. Cyclothymic disorder. Long-term pattern of many periods of hypomanic symptoms and many periods of depressive symptoms. These symptoms must last 2 years. Depressive periods do not meet full criteria for a major depressive episode. Symptoms must be present at least half the time, and there must be no more than 2 months without symptoms. They must cause significant distress or impairment. How common are mood disorders? Prevalence of mood disorders. Major depressive disorder has a lifetime prevalence of 16.6%. Almost 1 in 5 Americans will have MDD at some point. The average age of onset is mid-20s, but the younger generations are developing it even earlier. Older adults have lower rates of MDD compared to younger people. About 40% recover within 3 months and 80% recover within 12 months. 40 to 50% of people who have one depressive episode will have another. About 5 to 10% of those with MDE will later experience a manic episode. Persistent depressive disorder has a 12-month prevalence of 0.5%, which is much less common than MDD. Gender differences. Women are 2 to 3 times more likely than men to develop MDD. This difference appears after puberty. Before puberty, boys have equal or higher rates than girls. Race or ethnicity differences. European Americans have the highest rates of MDD. African Americans and Hispanic Americans have lower prevalence than European Americans, but African Americans often experience more severe MDD and receive less treatments. Native Americans have higher rates than European, African, or Hispanic Americans. Depression across cultures. Depression exists in every country, but symptoms and prevalence vary across cultures. How common are bipolar disorders? U.S. lifetime prevalence includes about 4% of people who have a bipolar spectrum disorder. Worldwide rates. The worldwide prevalence is about 2.4%, with 0.6% being bipolar 1. Ethnicity and diagnosis issues. True prevalence across ethnic groups appears similar for European Americans, African Americans, Hispanic Americans. However, African Americans are often undiagnosed for BD and overdiagnosed with schizophrenia. Hispanic Americans often receive less medication and fewer specialty mental health units. Age patterns. Adolescents have a higher risk of bipolar spectrum disorders than adults. About 50% of bipolar cases begin before adulthood. Older adults must have much lower rates. Causes and risk factors for depressive disorders. 1. Genetic factors. Family and twin studies show genetics play a major role in MDD. Individual-specific environmental factors also matter. A shared environment has almost no effect. 2. Stressful life events. One of the strongest environmental causes. It is very strongly linked to the first-time depressive episodes. This may be more important for later episodes. 3. Brain functioning. fMRI studies show people with MDD have increased activation in brain areas related to stress and negative emotions. 4. Early adversity and chronic stress. Increases risk for MDD. Childhood abuse or neglect, ongoing poverty, and long-term stress in daily life. Interpersonal relationships. Relationships can worsen or trigger depression. People with MDD may unintentionally create more interpersonal stress. Living with critical, overly involved family members increases the chance of relapse. Overall, bipolar disorder results from a mix of biological and psychological factors like strong genetics, differences in brain activity, stressful life events, sensitivity to rewards and sleep, and routine disruptions. All these factors interact to influence episode onset, severity, and relapse. Treatments for depressive disorders. People with major depressive disorder have many effective treatment options, including medications, brain-based treatments, and psychotherapies. There are many new treatments being studied, and they all show promise. In conclusion, everyone feels sad or unusually happy sometimes, but mood disorders involve symptoms that last much longer and interfere with daily life. Major depressive episodes are when people may feel hopeless, lose interest, and even have suicidal thoughts. Their view of future becomes very negative. Manic episode. People may act in risky or dangerous ways, such as spending way too much money or having unprotected sex. Afterward, they may feel shame or embarrassment. Major depressive disorder and bipolar disorder cause serious problems at school, work, and with relationships. Affect all people in all backgrounds. Treatment is available and effective. New treatments continue to improve. Getting help early is important. There are many ways to contribute to the field through research, clinical work, or efforts to improve prevention and treatment for mood disorders.